Welcome! I'm Olga, and today we're doing a comprehensive clinical deep dive into methylene blue as a mitochondrial electron cycler, a therapeutic tool that's gaining significant traction in functional and integrative medicine. I'm here with Harbor Health and Apothecary, and we're going to cover everything that you need to know: mechanisms, clinical applications, dosing protocols, drug interactions, monitoring requirements, and synergistic combinations. If you're looking to expand your mitochondrial support protocols, this is essential clinical information. Let's start with the science. Methylene blue functions as a mitochondrial electron cycler, bypassing dysfunctional complex 1 and 3 in the electron transport chain. It directly shuttles electrons from NADH to cytochrome C, enhancing complex 4 activity and ATP production by 30 to 40%, while simultaneously reducing oxidative stress. This is particularly valuable in conditions involving mitochondrial dysfunction like long COVID, chronic fatigue, neurodegenerative diseases, and mold toxicity. The compound also modulates redox balance, inhibits excess nitric oxide synthesis, and demonstrates neuroprotective properties through multiple pathways. What makes this clinically relevant is its ability to restore cellular energy production in damaged mitochondria while providing antioxidant protection. It's essentially giving cells an alternative energy pathway when their primary systems are compromised. Let's get into specific clinical protocols. For long COVID and post-viral fatigue, we're looking at 1 to 2 milligrams per kilogram orally daily, or 0.5 to 2 milligrams per kilogram IV over 30 to 60 minutes, 1 to 2 times weekly. The IV route provides higher bioavailability at 100% versus 50 to 70% that you get with oral absorption. Chronic fatigue syndrome responds well to 10 to 25 milligrams per kilogram daily orally, with some providers using up to 1 to 2 milligrams per kilogram IV weekly. The key is starting low and titrating based on patient response and tolerance. For neurodegenerative conditions like early Alzheimer's, Parkinson's, or mild cognitive impairment, we typically use 10 to 50 milligrams daily orally or 0.5 to 1.5 milligrams per kilogram IV weekly. The neuroprotective effects are dose-dependent. Treatment-resistant depression protocols often use 15 to 60 milligrams daily orally, though this requires careful monitoring for serotonergic interactions. The antidepressant effects appear to work through mitochondrial mechanisms rather than traditional neurotransmitter pathways. Mold toxicity in CIRS patients benefit from 1 to 15 milligrams per kilogram weekly IV, which helps restore cellular function after mycotoxin exposure. We often combine this with binding agents and other detox support. For cognitive enhancement in healthy individuals, maintenance dosing is typically 10 to 25 milligrams daily orally, often cycling on and off to prevent tolerance. Understanding the pharmacokinetics helps optimize dosing. Oral bioavailability is 50 to 70%, highly variable and dependent on gastric pH and food intake. Peak plasma levels occur at 1 to 2 hours orally, with immediate onset for IV administration. The drug is widely distributed and crosses the blood-brain barrier effectively, and has extensive tissue binding as well. Metabolism occurs primarily hepatically through demethylation, and renal clearance significantly reduced in kidney dysfunction. Half-life is 5 to 24 hours for oral dosing and 4 to 19 hours IV, which affects our dosing intervals. Most patients do well with once or twice daily oral dosing, while IV protocols are typically weekly to biweekly. This is where clinical vigilance is essential. Methylene blue is a potent MAOI and can cause life-threatening serotonin syndrome when combined with serotonergic medications. Absolute contraindications include SSRIs, SNRIs, MAOIs, tricyclics, tryptophan supplements, St. John's wort, linezolid, and certain opioids like tramadol and meperidine. Discontinue serotonergic agents at least 2 weeks before starting methylene blue. Moderate interactions include bupropion, monitor for seizure risk, and vitamin C in high doses, which may reduce efficacy, and NAC, which could interfere with redox cycling. Separate dosing for those by 4 to 6 hours when possible. Low-risk interactions include antihypertensives, benzodiazepines, and melatonin, but monitor for enhanced effects. High-dose niacin should be avoided due to potential BP changes, blood pressure changes. The key clinical pearl is always do a comprehensive medication review and don't assume over-the-counter supplements are safe to combine. Let's cover the complete side effect spectrum. The most common and benign is blue-green urine discoloration in nearly 100% of patients. This is harmless and resolves within 24 to 48 hours after discontinuation. Bluish skin or mucous membrane discoloration occurs in 10 to 25% of patients, is dose dependent but reversible. GI upset affects 15 to 30%. Nausea, stomach discomfort, metallic taste. Taking with food can minimize these. Neurological effects include headache in 10 to 30% of patients, dizziness and lightheadedness in 5 to 15, and agitation or anxiety in under 5%. These are often dose-related. More serious but rare effects include serotonin syndrome if combined with contraindicated medications, hemolytic anemia in G6PD deficient patients, chest tightness in under 1%, and allergic reactions, which are very rare. The clinical takeaway is that most side effects are mild, dose-dependent, and reversible, but proper screening and monitoring prevents serious complications. Methylene blue works exceptionally well in combination protocols. For mitochondrial support, CoQ10 or ubiquinol at 100 to 300 milligrams daily enhance electron transport chain efficiency. Acetyl L-carnitine at 500 to 2000 milligrams daily supports fatty acid oxidation and cognitive function. NAD plus precursors like NMN at 250 to 500 milligrams daily or sublingual NAD plus support cellular repair pathways. These combinations are particularly powerful for neurodegenerative conditions and cognitive enhancement. Antioxidant support includes glutathione at 500 to 2000 milligrams IV or liposomal, alpha-lipoic acid at 300 to 600 milligrams daily for cellular regeneration, and vitamin C at 2000 milligrams daily, though separate timing is preferred. For neurotransmitter support, SAMe at 400 to 800 milligrams daily and L-methylfolate can enhance mood benefits, while magnesium glycinate at 300 to 600 milligrams daily supports the stress response. Berberine at 200 to 500 milligrams BID provides antimicrobial and metabolic benefits, especially valuable in SIBO or metabolic dysfunction cases. Clinical pearl. These combinations often allow for lower methylene blue doses while achieving superior outcomes. Proper monitoring is essential for safe, effective therapy. Pre-treatment screening must include G6PD enzyme activity. This is non-negotiable as deficiency can cause severe hemolysis. Also, screen for serotonergic medications. Get baseline liver function tests, renal function tests, CBC, hematocrit, and mental status assessment. During initiation, weeks 1 through 4, monitor BP and heart rate before and during and after IV infusions or weekly for oral therapy. Track mental status changes, mood alterations, GI tolerance, and document skin or urine discoloration to reassure patients. Watch for medication changes and ensure no contraindicated agents are introduced. Optional pulse oximetry can detect any respiratory effects, though these are rare. Maintenance phase monitoring after 4 weeks includes CBC every 2 to 3 months for long-term use, liver and kidney function tests every 3 to 6 months, monthly BP and heart rate checks, and ongoing assessment of cognitive function, fatigue levels, and mood. For patients on IV protocols, pre-infusion vitals, medication reconciliation at each visit, and symptom tracking for efficacy and adverse effects are standard. Clinical red flags include signs of hemolysis, unexplained fatigue, yellowing of skin or eyes, significant mood changes, or any signs of serotonin syndrome. Here are key insights for optimizing therapy. Always start low and titrate slowly. Begin with 15 to 50 milligrams daily oral or divided doses for most conditions. For neuropsychiatric conditions, even lower starting doses of 5 to 10 milligrams may be appropriate. Timing matters. Recommend morning dosing as methylene blue can be stimulating. For twice daily dosing, give the second dose before 2 p.m. to avoid sleep interference. Taking with food reduces GI upset, but may slightly decrease absorption. For maximum bioavailability, dose 30 minutes before meals, but patient comfort is often more important. Maintenance dosing for chronic conditions typically ranges from 15 to 50 milligrams daily, with some patients requiring higher doses up to 100 to 200 milligrams daily for refractory cases. IV protocols allow for higher effective doses with better tolerability. Typical range is 0.5 to 2 milligrams per kilogram weekly to biweekly. Always use proper dilution and infusion rates to prevent local reactions. Now, let's hear from our chief pharmacist, Nick, on some commonly asked questions about methylene blue protocols and clinical applications.
Yeah, well, thanks for joining us here at Harbor Health and Apothecary. Today we're going to just go through a few of the most frequently asked questions with methylene blue. And so one question we often get in the pharmacy is what formulations are available to use with methylene blue? Methylene blue, from a compounding perspective, is really, really messy. And what I mean by that is it tends to stain everything that it gets on. And so when we compound, we're really looking to try to get the powder into a liquid form as quickly as possible, so we have less of that powder getting on our equipment and also getting on personnel that are working on the actual compound. So most often you're going to see methylene blue in a liquid formulation, and again, from our perspective, is that's the least messy way to make methylene blue. And so you'll see methylene blue come in capsule formulations. When it's in a capsule formulation, the way that we do it is we take the methylene blue powder and we dissolve that powder in some type of oil base. And once we have that powder dissolved in an oil base, we draw up a specific volume and we fill capsules with that liquid, that methylene blue liquid. You'll also see it in sublingual products, so you might see it in a suspension, and you might also see it in a troche as well, or a tincture. Now, those products work perfectly well. There is one thing that you do want to be aware of when you're using something that's sublingual with the methylene blue that has the staining capability, is that you can stain the oral mucosa as well as the teeth. So that's just important to let the patients know, is if they're taking a liquid formulation of methylene blue or a solid dosage form like a troche, that they could potentially see staining with inside their mouth. And sometimes that staining will resolve, and sometimes it might stay as well. Some quick tips is, after the patient's taken their sublingual dose, is they can rinse their mouth, and sometimes that can help reduce the staining or prevent the staining of the oral mucosa. So another common question we get is the pharmaceutical grade versus commercial grade methylene blue, and whether or not that's important. I'm sure all of you as practitioners have probably had, at one point or another, the patient come in and say, well, I can get methylene blue off of Amazon or some other website. Now, it's important to know that methylene blue's first use was as a dye, so for dyeing blue jeans. And so there is a big difference between pharmaceutical grade and commercial grade methylene blue products. The pharmaceutical grade is going to be the purest form of methylene blue. As well, it's not going to have all the contaminants that the commercial grade product might have. And the one thing you want to be aware of as a provider is, if you are using a commercial grade product, the contamination of heavy metals in those products can be significantly higher and outside the range to be used for human consumption. And so that's one area that we always talk to the patients about, and providers, when we're educating about methylene blue, is that we do use a pharmaceutical grade that has actually no heavy metals in it, and it meets the requirements for human consumption. So now we're going to roll into talking about dosing for oral methylene blue. And so dosing usually starts at 5 to 10 milligrams per day, and then the patient slowly titrates up. And the reason why they're titrating up is sometimes methylene blue can cause some GI distress. Once the patient gets up to 25 milligrams daily, if they're going to titrate up to the 50 milligram dose, then what's usually done is they take the 25 milligrams twice daily. And again, that's because methylene blue can cause some GI distress in some patients. And so once you're at the 25 milligram mark and you're getting ready to titrate up to 50 milligrams, it's always good to split that dose into a twice daily dose.
Methylene blue represents a unique therapeutic tool in our toolbox for addressing mitochondrial dysfunction at the cellular level. From long COVID recovery to neurodegenerative support for cognitive enhancement, its applications continue to expand as our understanding of mitochondrial medicine grows. The key to successful outcomes is proper patient selection, comprehensive screening, appropriate dosing protocols, and vigilant monitoring. When used correctly, methylene blue can provide significant clinical benefits with an excellent safety profile. As we continue to see more patients with complex, multi-system conditions rooted in cellular dysfunctions, compounds like methylene blue that address the fundamental energy production mechanisms become increasingly valuable. Remember, this is a precision medicine at the cellular level, and when we get it right, the clinical results can be transformative. Thank you for your attention to this comprehensive clinical overview. Your patient's mitochondria and their quality of life depends on this level of clinical precision.